Welcome, everyone. So I'm going to be talking about modeling COVID-19, called a primer and an overview. And what I'm actually going to do today will be fairly fast-paced, and it's going to start from the ground up, look at the modeling process, what gets done, and then look at a bunch of different kinds of issues that are raised in this modeling and how to address those. But before we get started, I want to very briefly go over the mechanics of the webinar. You will have a little grab tab, which shows up in the typically the right part of your screen that you can hide or show things with. It has audio setup that will allow you to listen. And then there is a chat. And so if you have questions that you want to ask, or if you're having any difficulties, just put them in the chat, send them across, and we will hopefully be able to address those. I will be stopping for questions at a couple of different points during the webinar. The questions that you type into the chat, we will, Kareem Shockley will be reading out so that we can kind of discuss those, and that's what we will do. So without further ado, let me begin. So as I say, kind of got two different things, a little bit about background on the COVID-19, although I guess that's probably unnecessary since it's in everyone's face every day right now. And then a primer on the basic diffusion model, then the standard SIR model, which is a derivative of that, and the kinds of interventions that are typically done in that to show the effect that they have. I'm going to go through that fairly quickly. I'm going to build it from the ground up. I'll be building it using Stella version 2.0, which has some kind of neat features that are fun to look at for this particular model. And then I'm going to go over an overview of issues with some of the solutions we have for things like distributions of transmissibility time, clustering effects, extinction, viral shedding profiles, disease stages, integrating healthcare, and I'm actually not going to show you anything on this, but I just point out that it's an issue, including the economy. And then we'll have a final question and answer period. So without further ado, I'm actually going to jump into getting work with a standard SIR model. I want to kind of the reason that I think this is important to do is there are a lot of people who are talking about projections of number of people who are getting cases and the number of deaths and everything that's coming up. And those projections are all based on models. And the typical model is an epidemiological model, the kind we're developing today. So I thought it would be useful just to go over what that is. For many of you, this will be a peer review. For some of you, you may not have seen this before. And then be able to talk to, well, what are the strengths and weaknesses of that? And what are the special challenges that COVID-19 presents to us when we're trying to do these types of things? So this is a blank model. I'm actually going to start from scratch, so to speak, and I'm going to do a population of 1 million. So we'll put down a stock. I'll zoom in so it's a little easier for everyone to see this. I may have zoomed in too much, but we'll get there when we get there. We'll put down a stock. We'll call this susceptible. And I'm going to say that there are 1 million people in the susceptible category. I'll use 1E6 so I don't have to count my zeros. And then I am going to have a set of people who will be infected. And as I say, I'm going to start with what's called the Bass diffusion model. And that's a model in which you move from susceptible to infected, but never move out of infected. And so we have a flow, which I will call infecting, which moves us between susceptible and infected. And so I'm going to start with a single infected person. And I'm going to run this model from 0 to 100 days. This is one of the rare times where you can look at something and the only units of measure that make sense for looking at are really days. And people move from susceptible to infected based on infecting, and the process of infecting is one that starts with contacts. So an infected person will contact other people based on what we typically call originally a contact rate. And so the number of contacts is the number of infected people times the contact rate. This will be person per day. Or we can, actually I'll use in this model, I'll use touch per day. A contact is an interesting concept because it's actually something that's contextual to the kind of problem you're dealing with. In this case, we're looking at an interaction between individuals that are within 6 feet of one another, or an interaction that occurs as a consequence of touching the same surface at similar points in time. Anything that could cause the virus to transmit from one person to another person. So I'm going to use a contact rate of 80. That'll be touch per person per day. And the reason I'm using this is there is an infectivity effectively number of 0.45%, which has been established in some of the literature, and I'm going to be using that. And the contact rate and that infectivity number are the two things that combine together to kind of tell us what's going to happen. And since I've got one of those values available from the literature, I'm going to make use of that. So actually I'll do that now. Now, infectivity does not pass spell check. And I think that's just the way it is. I should add that to my dictionary. I hope I spelled it right, because I'm not going to live with it for the rest of my life. And I'm going to put that at 0.45%, which is 0.0045. And this is person per touch. Another way to think of this is it's the probability that a person will become infected as a consequence of having a contact with an individual who is infected. So you see that contacts is only of infected people. Of course, susceptible people are also making contact, but it's only the contact between a susceptible person and an infected person that is of interest in the propagation of the disease, since the infected people are already infected. And so in order to recognize that, we need the fraction of people who are susceptible. And that is done, there are a couple of different ways of doing it. I actually, for this particular setting, like using a summing converter. And the reason for that is that it's going to be total population, which will be the sum of susceptible and infected. So I'll call it total population. Because it doesn't draw an extra set of connectors between these two stocks and this, which might suggest that there's feedback, when in fact all this is a constant number, the way things are setting up. So I don't really want to emphasize that feedback because it doesn't actually do anything. It's an artifact of the way I'm constructing this model. So that and the number susceptible determines a fraction of people who are susceptible. So that's susceptible divided by the total population. This is a dimensionless concept. Total population, I hope I put people in. Try to be very careful about units. And then infectivity is person per touch, and that's going to come in a little bit afterwards. So this is a fraction of people, so this will be another converter. And I could have gone directly with all these together in the flow. I'm going to actually just do out contacts with infected and infectivity. This will still be touch. This will now be touch. Some of you may have noticed I made a mistake. This infectivity is supposed to be going into infecting. not into contacts with infected, and it is contacts with infected also goes into there. So infectivity is contacts times a fraction of people who are susceptible. And then infecting is the contacts with infected times infectivity. And so what this now says is you've got some infected people, they come in contact with other people. Some of those people they come in contact are susceptible. When that occurs, there's a chance that they'll become infected, and that gives you an number of people who are infected, and that gives you this model. So if we run this model, what we get is the classic transition S-shaped adjustment, where the susceptible starts out big, infecting starts out small, but then it goes up, and infected comes out big. So I'll just drop a graph of course, I'm zoomed way in, so the graphs always end up being kind of funny in scale when I do this. I'll put infected on the graph and infecting on the graph. And I'm just going to put those on opposite scales so you can see the difference. So we get a period of time over which we get infecting, which is quite short, and the number of people goes up. And you'll notice at the end of this, the susceptible people is at 0, a trivial number, because there is, in this model, only 2 categories you can be in. You're either infected or you're not. If you're infected, you're infecting others, and as a consequence, susceptible will go to 0. What we can do, of course, is change the contact rate, and we'll see that with a lower contact rate, you move to the right, so-called flattening the curve, the number of contacts. And you see also that the scales are changing. I didn't set scales on this, so that the original number was at 90 as it moves down. The other thing to notice here, which I haven't pointed out, is all of this annotation around the diagram between the different elements of that. And if we look at the way that kind of behaves over time, actually, if I just make the simulation run a little longer, it may be the easiest way to see it. So I'll run this for 10 seconds instead of 5, instead of 1. You can see what happens is at first there's a very strong positive feedback loop. And then as the number of susceptible people goes away, that loop gets weaker. You can see that because there's a small link here, the weak link that's shown here. And this loop here, susceptible to contacting, which is the running out of people loop, if you will, and it's a balancing loop, gets quite a bit stronger. And if we look over in the loops panel, we can see the 2 loops. First of all, the reinforcing loop is very big, and then it starts to go away. And when it starts to go away, the balancing loop, which was basically not doing anything at first, comes into play, and it becomes bigger. And because it's balancing, it has a negative number here, and the reinforcing loop has a positive number. And so we can see the transition from a positive feedback loop in this part to a negative feedback loop here. And there's just one period of time, and it's like if you look closely, what it is, it's exactly the peak in infecting that it's happening. We're transitioning from a positive feedback loop to a negative feedback loop. So that is the BAS diffusion model. I wanted to just pause for a second in case anyone had any questions on this. What I want to do from this is obviously build it out to the standard SIR model, which is the one that's used quite commonly in looking at infectious diseases. Kareem, are there any questions that people have?
The only question is a couple people have commented that contract rate is misspelled.
Wow, that's a good catch. Okay, so we have that, and if we want to do a recovery model, what happens is my graph, I'll put it up here a little bit. We just add another stock, and that is a stock for recovered. This is why it gets SIR, susceptible, infected, recovered. Just using a capital R. And we will start this out clearly with 0. This is going to be connected through that. That process, I'll just call it recovering. And what's happening is that if you are infected, there is a disease duration. And I'm going to use 14 days for the disease duration. And then recovering is the number of infected over the disease duration. This is days, I fill that in. And the other thing that's happening, of course, is we're now allowing people to go out of infected, which means that total population, if we just ran it the way it is, would be going down. So we need to add recovered as another element of total population. Again, the advantage of using a summing converter here is in addition to not creating false feedback loops, I'm not creating a whole bunch of extra arrows on the diagram, which would have kind of cluttered things up. If I run this model, many of you know what this will do, and we can run it, and I ask it to run really slowly. So there are two things to notice. One is that the number of infected people also goes up and goes back down. And if we were to look at a comparative graph, in terms of the loops, we've added in another, we still have the original positive loop, which is there, and it's the strongest at first. But we also have two negative loops. And I'll just make this a little bit bigger so I can highlight them. So we have that negative loop, which is just the infected to recovering, which ends up being important towards the end because most people are in the recovered. And then this feedback loop, which is the reinforcing one at the beginning, and then the other running out of people to become susceptible towards the end. And here we see there's this movement along the chain. And if we compare, we do a results comparison, for example, to view results on infecting. Then we have this. The number of infections is lower and more spread out. And the total number of people getting infected, right now, it's not changed much. Almost everyone in this population is being infected. But if we go through and change the contact rate in this model, bringing it down, first of all, we go past 100. So let me go and run this model from 0 to 200, just so we can see how it kind of plays out a little bit more completely. I'll go 365 because that's a year, so it's a little bit easier typically to just think about what that means, even though the labels on the axes look kind of terrible. And then look at the contact rate, and as we lower that, you can see as it gets lower, what's happening is we're moving it out, we're moving it to the right, it's getting wider and smaller. But the other thing that's happening is the number of susceptible people in the end is no longer 0, which is to say that not only are we moving it to the right and making it somewhat lower, but we're also decreasing the amount of area underneath the infection curve. We actually decrease the number of people who get infections. And this, the reason this is happening goes to what concept which we could really call R. So many of you have probably heard of R naught quite a bit of late. And R naught is the reproductive, I'm going to actually create something called R, and then I'll create something called R naught, kind of a two-stage process here. R is the reproductive capability of the disease, and the inputs to that, I'm going to just do these as ghosts, so I don't have to draw them across the thing, is the contact rate, the infectivity, I was going to say, I'm even going to do disease duration as it goes, so I'll just put this over here a little bit more. The disease duration and the fraction of people who are susceptible. So R is actually the product of all of these things. Sorry. Wrong. Alt key. So it's the fraction of people. Yeah, let me actually do it in the right order. So it's effectively, it's the contact rate times the infectivity times the disease duration times the fraction of people who are susceptible. And hopefully I can suggest units for that. It's a dimensionless concept. It is the number of people who are going to be reinfected by a person at any point in time, and R naught is basically the value of this when the fraction of people susceptible is 1. And I'm going to just do it as the init of R. And now if we run this model again, I'll speed it up a little bit. Back to a second. And take a look at, just scroll over so we can look at the behavior of R over time. So if you look at what's happening to R over time, R starts at 5 and goes down to 0.03. That's because we run out of people. So at the end of it, one person is infecting only a very small number. But if we look at R naught, which I forgot to name, sorry. I too have trouble sometimes making the right mouse clicks on things. To stock this, if we look at R naught, it's showing us 5. And of course, the interesting thing here is that if you change the contact rate, R decreases. So it's really determined by the contact rate. But the other thing that you change is the disease duration. A bigger disease duration gives you a bigger R. We're showing R. And actually, I can just put it in numeric display, easier. So a bigger disease duration gives you a larger R naught. A shorter disease duration gives you a smaller R naught. And if you go back to thinking about this original model that we had, just susceptible and infective, that's the same as saying that the disease duration is infinite. And so you can imagine in that case, the R naught of the disease is also infinite, which is why you're guaranteed in that kind of a setup, no matter how small infectivity or the contact rate is eventually everyone will move from one stock to the other stock. For a disease, when there's recovery, depending on how long the disease duration is, you do not necessarily get this complete movement. And we can see with a smaller contact rate of, say, cutting it in half to 40, we get an R naught of 2.55 instead of 5 the way it is set up right now. And of course, R itself goes down from there towards 0. And once R is below 1, if R naught gets below 1, so we need to just rearrange things here a little bit. Let me just move R naught over here so we can look at it. If R naught gets below 1, it's a little messy, I apologize for that. But if R naught gets below 1, so we drag it down 0.95, you see all of a sudden, as soon as it crosses that 1 threshold, we go from something that's taking off, 1.42, to something that's actually just declining. Never would have seen this. You've got one infected person. That infected person will infect a couple other, well, no, will infect less than one other person. So there's just this draining, and the disease actually won't end up doing anything. And that is what I want to do in terms of introducing things that can improve the situation, policy adjustments. And the policy adjustment we've all been seeing of late is, of course, a change in the contact rate with an attempt to use social distancing as a mechanism to decrease the transmission of the disease. And representing that is fairly straightforward. like to put in a start. So this will be when we start changing the contact rate. And I'll call this the base contact rate instead of just the contact rate. And then our sort of global quarantine effectiveness. So the global quarantine effectiveness will tell us how much we've managed to reduce the contact rate. So contacts, instead of just being infected times the base contact rate, we also multiply, we check to see if we've started our quarantine. So actually a couple ways of doing this. I think I'll do it as a multiplier times. If time is bigger than the start contact change time, then we have our global quarantine effectiveness, or let me do 1 minus, actually I'm going to use effectiveness. I'm going to change the name of this because the other models I'll show you, I think, use a zero-based one, else 1. So this says that once we get past the change time, we'll do this. I'm going to rename this to multiplier. And this is a multiplier that's 1, means nothing's happening in the quarantine. And if it's 0.5, it means we've reduced the contacts to half of what they would have been, effectively reducing the R naught to half of what it would have been. Although when it gets imposed, we'll already have some fraction of the population who's no longer susceptible. So the R at that point is a slightly different concept. And then I'll start this at, say, I don't know, 30 days in or so. And then you should be able to see, I didn't make any mistakes. Obviously I did. If infected. This one global quarantine multiplier is 0.5. So, oh, I started it too early is all. You can't see the results. So I need to start it at, if you want to see something significant, about time 50. Just in terms of being able to kind of see the results. And you can see what happens then is, let me do restore all. That at time 50, we get an immediate reduction in infecting, and the number of infections goes down. And if we look at the behavior of our R variable, oh, I don't have I use the base contact rate in this one, not the real contact rate. It's my mistake. I didn't set that up quite right. It also gets cut way down. And as a consequence, you end up with still a fair number of infections, but that dies out much more quickly than it would have if that global quarantine multiplier had been closer to 1. And then we can play with when the global start date is. 50 is actually a little late. But you can see, moving it around, that it changes the nature of the curve, and actually starting earlier kind of moves the curve to the right. It's just totally counterintuitive. I think it's correct. And that's one kind of intervention. Now, the other kinds of interventions you can do in this model, and I'm going to, at this point, for the sake of time, pull up a model that has a whole bunch of interventions in it. So I'm going to open models. I have SIR, various interventions. So this is the same thing we've been looking at, but I've added in some additional interventions. One is vaccination, which pulls people out of susceptible and puts them right into an immune. category. Another one, I've got the social contact rate and adjustment start time, contact adjustment coming into contacts, which we just went through. And then I also have a disease duration with a therapeutic intervention. So vaccination is obvious. It's something you can give people that will make them less likely to get the disease, which build up some sort of immunity. And then therapeutic interventions, there are a couple different types that can be used. The antivirals that might be used, for example, would decrease the severity and length of the infection, and using antibodies from recovered people would do a similar sort of thing. This is a little bit simple-minded, because I'll get to showing you some more kind of complete layouts of what's happening. But this allows us to kind of look at what happens. Here we have an intervention, contact adjustment to 0.5 at time 35. We can see the contacts are going down. Just move things around a little bit for you. Okay, trouble manipulating my software. Contacts are going down. And then we can do things like take a vaccination rate and increase it. And a couple of interesting notes on the vaccination. Obviously, there is no vaccine. But if you want to really change the course of a disease during an epidemic, the vaccination rate has to be pretty astonishingly high. We can almost take care of this this whole thing by vaccinating 2% of the population every day. If you think about the implications of vaccinating that many people, it's pretty amazing. So vaccinations obviously are really important in the long term, but in terms of dealing with an ongoing infection, it's not much of a strategy, because it's just there's too many people that have to be vaccinated. So that's difficult to do. And then the therapeutic intervention, what it effectively does in terms of the epidemiology, is really just to make more people recover more quickly. And since more people are recovering more quickly, there's less time that they're sick, so there's less contact with other people, and that can also substantially lower the curves in terms of what's happening. So that's kind of SIR with the various interventions that are typically done, and everything's being presented in what I'll call a bathtubby mode, and that's one of the things I want to get to next. But I wanted to pause to see if there are any questions on that so far.
There are a lot of questions, starting with parameters. How do you pick them? How did you pick them? Are they just assumptions, especially infectivity?
So the parameters are assumptions. Infectivity, I say, was the result of a study. I don't have the citation on the top of my tongue. And then the contact rate is kind of its counterpart. And the two of those together are picked to try and replicate some of this, what we've been seeing in different settings. The other one, so all of these, one of the very interesting things about COVID-19 is there is so much variation in individual cases, and there is very little knowledge about many even of the mechanisms of transmission. So it's clear there's asymptomatic transmission. There are claims that there is a large number of people who are totally asymptomatic over the entire course of the disease. There are countervailing claims that that's never true. So there's an awful lot we don't know about it. But yes, the parameters need to come from a variety of scientific studies. Some of these are very small samples, some of them are relatively big sample. One of the problems with an epidemic that's moving at the rate that COVID-19 is that the studies being done are being done at the same time you're trying to deal with frontline patients. And as a consequence, a lot of the data are really just not very good at this point. So it's a real struggle. That's the long and short answer, unfortunately. What else do we have?
The other big question is, where are deaths? What happens to people who die?
Oh, yes, people who die. So this is not in the SIR model. And of course, it is in real models. And we will get to some models that show deaths and whatnot. But I wanted to go through some of the other questions that I had raised. So I'll probably get to that in sequence. I'm going to look at some of the other issues I had raised before I get to that.
The next question is, what if you split infected into symptomatic and asymptomatic?
So everyone's jumping further down the chain of presentation that I'm going to do here, but that's definitely something that we want to look at. I don't have time to do that in front of you. I'm going to show you a model that does that and actually lays things out in quite a bit more detail. But it actually is still the same basic structure. In fact, COVID-19 is interesting because the viral shedding, the extent to which a person is infected has a interesting, although it's not completely well defined, but there's a lot of evidence that it's very high early in the disease and then tails off later in the disease. And unfortunately, early in the disease also when they're most likely to be asymptomatic. So there's an upmount, which is kind of bad news for managing a disease. There's a lot of infectivity early on, and it goes down substantially as the disease progresses within an individual. But I'm going to show you a model. That part of it, the profile of infectivity isn't there, but I'll show you a model where there are different stages of disease with asymptomatic and infected, and then moving through to no longer infecting people.
Related to that was the question of recovered people becoming susceptible again.
I'm not going to deal with that in today's webinar. That's a really interesting question that right now there is very little good information on, but it's certainly a concern for a lot of people. And it would be it's a game changer in terms of the long-term management of this disease.
Okay, and then a more general question is your model already being used for policy response in any government?
So the models we have developed are not being used in policy response, but there's quite a consortium of people. We're getting them out there on the web for people to share. And actually, that's one of the purposes of this webinar, is to give you a bunch of little insights, almost like molecules for COVID-19 modeling of ways of doing things. And some of those insights and ways of doing things have made it into models that are being used. So the original intent that we had was to kind of make more transparent the techniques by which these models are developed and what they're saying on things. And our hope is we can sort of increase the overall quality of the models, not only by doing it ourselves, but also by making the raw materials of what we're doing available to as many people as possible.
Okay, one last question for now. Someone wants to know if you could re-explain the distinction between R1 and R0.
So R0, which is all anyone ever talks about, this only has an R0 in it, is the rate of reproduction. How many people an infected person will infect on average if the entire population is susceptible. It's called not because that's at the very beginning of an epidemic or an outbreak, that is the nature of everyone is susceptible. And then as time progresses, fewer people are susceptible. So the actual number of people that an individual could infect will be going down over time, which is why I did a separate R that goes down as the number of susceptible people goes down. But R0 actually is the one that most people talk about. Now, one thing worth noting on R0 is that it is the product of infectivity and the contact rate. Those two together determine that kind of speed of the exponential growth rate, if you will, during the uptake part of that curve. And finally, the disease duration. So if you have a really long disease duration, think hepatitis C, for example, even though it has a relatively low infectivity, or you can think of it as a low contact rate, it's not something that's passed casually. It has a fairly high R0 because it has such a long disease duration. So COVID-19 has a, relative to its diseases like the flu and colds, a very long duration, very short relative to something like hepatitis C, obviously. But it is one of the things that adds to a big R0. But the real scary part about COVID-19 is the infectivity. A casual contact has a 0.545% chance of leading you to getting the disease. And we've seen that in the Biogen case in Boston and in the Boston area and whatnot, where a large number of people are infected from what seems like a relatively small activity in the scheme of things. Like 1/3 of the people at the conference, the Biogen conference, were infected with COVID-19. That's the scary part of it. And that's also why it grows so fast, because this infectivity is so high. Okay, so what I wanted to do was talk about some of the different assumptions. And let me actually do them in the order I've got here. So there's a distribution of transmissibility time. Oops, sorry. So let me open up model, which I will do. It's called social distancing combined. What this actually is it's 3 copies of the model we've just worked on. The model we just worked on was this one. We have susceptible, infected, recovered. We have a total population. We have infectivity that's coming in from, for those of you who are not familiar with modules, it's just a way of organizing content in models so that you don't have to have everything on one big page. But this is really the model that we've been working with. We're getting these parameters in from outside so it's easier to look at them. And then I said, well, what happens if you've got not perfect mixing? So a perfect mixing is interesting. What it means is that if a person becomes infected, the distribution of times that a person is infected is a negative exponential. And what that means is that becoming infected, the most likely thing that will happen to you is the next DT, actually, which is a quarter of a day in this model. You will no longer be infected. You will be in recovering, and then you'll be recovered. So the vast majority of people, just by the counts, spend no time at all in this infected stage, and they spend all their time, they're either insusceptible or basically in recovery. That, of course, is not a realistic way of thinking about what happens when you get the disease. And so the not mixing version of this is one in which we say, well, there's a profile which looks like this. This actually happens to be a Weibull distribution. And if you, for nobody do you like stay for 0, but some people don't stay for very long, but most people stay for kind of a middle-ish part of it. This is roughly the mean, the peak. And then some people stay longer. And this is an average transmission time, an average disease duration. We're still using 14 days. But the transit time, the amount of time you actually could be in there, varies from 0 to 30 days. So this is a new piece of functionality that's gone into Stella 2.0. But what we can do now is say, okay, when people become infected, they become infected with using this profile. And the amount of time they will spend in the infected stage then follows this profile, recovering into recovered. Everything else about this model, except for the fact that this is a conveyor, is really the same as it was with the perfect mixing model. And then just to kind of show completeness, there's a discrete version of this model where every one of these, instead of being a population, is an individual. And the individuals are susceptible, they're infected, or they're recovered, and their recovery time, which is the time they spend in the infected stage, also uses a Weibull distribution to determine how long they will spend in the infected stage before they come out and go recovered. And if we go back to this model, the interesting thing about this model is I'm using kind of the same setup. The blue line is that not mixing, where we use the Weibull distribution, but still a complete population. The jagged line is the discrete, where we're using the agent-based, and I'm actually just adding up all the individuals in the different stage. And this is infected. I can look at infecting as well, all the individuals who are infected. And the dashed red line is the model that we've been working with, I call the perfect mixing model, in which we just use stocks. And you can see that they behave in a very similar way, but there's kind of a substantial distortion in terms of the time range on the perfect mixing, the model that we were using, relative to the both the discrete individual model and the not mixing model, which tend to look pretty good. But I'll have to say this, and if we do manage to get to extinction, which I don't think we're going to, unfortunately, you can see that there can be multiple runs that this does different things. But one of the most interesting things to note here is the contact rate I had to assume to get these things to match up was 48.6 for the perfect mixing model, but only 40 for the discrete and for the not mixing model. And what that means is that if you're making the assumption of perfect mixing, you end up having to distort the basic parameters of the model in order to get the two curves to kind of work together, which in and of itself is not usually an issue. But because the COVID-19 has a very long duration, and because we're taking very drastic measures in social distancing, it does mean that the predictive accuracy of those models in response to the social distancing changes is likely to be degraded as a consequence. And I'll show you in the summary, we've got some examples. There's a little interface that kind of demonstrates that. The next thing I want to talk about is clustering effects. And clustering effects are interesting in that when a disease begins to propagate, it doesn't just show up everywhere all at once. It shows up one or two places. And I have hopefully named these various standards. Sorry, using delay distancing. Cluster, sorry, I can't even read. I'd say I can't read my own writing, but it's my own typing, and I should be able to read that. So this is a clustering model, and what this does is there are 100 different communities, each of 10,000 people instead of one community of 1 million people. And the infections go on in a cluster like they would otherwise, but the contacts are contacts between the in-cluster population. This is the contact within a cluster. If you look at the risky contacts here, it depends upon whether the crossover out of cluster contact rate, if you will. And so this adjusts for the contacts you get from people out of your cluster with contacts you get from people within your cluster. And if we run this model, it runs a little bit slower because of the 100 communities. What you need to do in order to make this non-clustered version of the model match up is you need to do some, we use 85 as the contact rate for the unclustered. We use 85 is the contact rate here, but I've actually added some additional structure in the unclustered one to say that there's a cluster effect. The cluster effect over time looks like this. It starts out at 82% and it moves up. And what the cluster effect does is at the early stages of susceptible, when most of the population is susceptible, it actually decreases the infectivity across things. It slows the progression of the disease, which is the kind of thing you will see within when you have things working within a cluster. So this is a mechanism for dealing with the fact that we're actually treating people as if they're all in the same place instead of having clusters of the disease break out. And compensates for that. This doesn't end up being very important when a disease has gotten more than 10% or so. In fact, I think the cluster cutoff is 10% here. More than 10% or so of the population has been infected, but it can be very important early on. And in very early stages of a disease, it is extremely important for doing contact tracing and whatnot. I'm going to say just a word on extinction. Oops. So all of these models are available. I didn't have as much time as I thought I would, or I didn't talk as quickly as I thought I would. But I do want to look very briefly at extinction. So extinction is a model that has a not mixing, a perfect mixing, and a discrete variant of it. And if we look at these and just run it, and this is running a randomized thing where there's a 50% adjustment in behavior. And what happens is the perfect mixing and not mixing both go through an epidemic, whereas the randomized discrete does not. But if I run this again, it's pretty likely, this would be embarrassing if it runs it twice in a row and does this. Okay, also dying out. This is the trouble with using non-seeded randomizations. They always produce different results. Okay, so here's one in which we get a bit of an outbreak and it dies off. And then it picks up much later on in the game. And so this is actually unfortunately realistic. It is if you're dealing with things where you actually get a disease down to a small number. You can get extinction in a agent base, which would be more like the real world, whereas it's hard to replicate that in there. But I did put in this model some adjustments for getting the extinction if the contact rates end up going relatively low relative to what's in there. So that does with that. I really probably should be quiet. They're setting disease stages, integrating health. So I'm going to just show you one last model, which is kind of a more complete model that does a lot of this stuff together. And then I'm going to take as much time as I can for questions. So this is a model that incorporates the disease transmission, so the epidemiology that we've been showing so far. And in addition has a healthcare responsiveness, which is a hospitalization section. So you can have people needing hospitalization coming into the hospital, potentially going into ICU in the hospital, but also a waiting list. And one of the biggest scary things about COVID-19 is if this capacity is limited, we put people on the waiting list. The vast majority of deaths, if we get a true, if we don't manage to control the disease, the vast majority of everything is happening here, which is actually outside the hospitals, as horrible as the situation as the hospitals may be. And then this model also deals with healthcare workers who go through the same kind of progression of diseases potentially and can have an impact on the capacity of the hospital. It also has a supply chain for materials in which shortages can cause degradation in both the quality and ability of hospitals to deal with patients. So that's kind of a more complete thing. And the basic epidemiology here, one of the early questions was about stages. This is actually the same kind of model, but we have an infected, not contagious, so the early infection. Then we have an asymptomatic and contagious. Then it becomes symptomatic and contagious. And then the viral shedding kind of goes off. You're no longer contagious, but you remain symptomatic, requiring hospitalization and whatnot. And this model also deals with testing, which I haven't been able to mention so far. And any of these groups of individuals can be brought out through testing. And once people are tested, we have behavioral assumptions that show that they behave differently depending upon what their category is, whether they're symptomatic or not, whether they've been tested or not, and whatnot. And so this epidemiological model, there's a link for it I'll show you in the final slide. And it's being combined with kind of the support system for healthcare, and eventually, if we get there, with some of the economic factors that are being influenced by the epidemic. So that's there, including the economy. So questions, sorry I ran over in my own talking, but I'll try and answer as many questions as I can.
Okay, the first question is, oops, hang on, sorry, scrolled on me. Have you done any variations that have people respond more completely to quarantine information as information spreads about the illness rates and deaths? So the dynamic response, right now there's a static response to quarantine effects. So one of the things we want to build in is a dynamic response. We do have data on infections and deaths by metropolitan areas. And I'm going to see if we can't use that to tease out some of what's been happening with respect to both responsiveness of the quarantine. And really, from my perspective, the big unknown is this asymptomatic transmission mechanism. I just am not satisfied that it is well enough understood from what is happening. So the answer is we haven't done that yet, but that's on the list of things we're very interested in looking at. How would you deal with an only partially effective vaccine?
So vaccines are always only partially effective. And the advantage of these kind of high-level aggregate models is that you can just say, oh, it's 50% effective, so you get the vaccine, there's a 50% chance you become immune and a 50% chance you don't. Getting into the behavioral details of how people behave after taking a vaccine that they think is effective, that is not effective, becomes a little bit more subtle, but you certainly could kind of lay that out very much like the way we laid out the testing thing in the more detailed epidemiological model.
Great, thank you. Have you looked at comparisons between social distancing, quarantined, like absolutely quarantined, you can't go outside, or stay at home?
We have not looked at those. So the data out of Wuhan and China in particular is not completely reliable. So the answer is no. Those are really, really good questions. It's going to be, to do that, you're going to need to look at a lot of data. China, Italy, Singapore probably has really good measurements, very small population though. And that may give us a better handle on it, but no. I wish I knew the answers to those questions, but I don't.
Can you incorporate how personal protective equipment might help prevent transmission?
Yes, and that really is in the hospital setting when that becomes the most important in the kind of combined model that I began to show you, where the disease transmission within the hospital. For example, in Wuhan, 100% of the people working in the hospital ended up being infected with the disease. So that becomes a really important factor to look at in the hospital. And that's one of the reasons we started building in the shortage of supply chain equipment for that kind of equipment getting into the hospitals.
Can this model take into account demographic differences in the population in different geographic areas?
So this model, so far, none of the modeling we've done has been age-based. It's really a matter of time and computer time to some extent, and human time as well, to kind of break it out. We have pretty good demographic data, obviously, on different regions in the United States, so it would be possible to do that and to look at those effects. I'll be honest right now, I'm not sure, because there's so much uncertainty about some of the basic epidemiological parameters of the disease. Other than a really gross cut, which was kind of older people and not so old people, I don't know how much we would learn from a more refined cut on demographics at this point.
What is your assessment on the integrity of the outcomes shown in this model?
The outcomes shown in this. So
like how useful they would be for policy or whatever use.
Until at this point, I think they're very illustrative of the relationship between the assumptions and results. But until I spent more time calibrating this model to data, I don't have a lot of confidence in the actual numbers that are coming out at all. One of the things, there are some important insights. One of the most important insights is that if we which is like dead obvious when you think about it, if we overwhelm the healthcare system, the people who die are not going to be dying in hospitals. And I think a lot of people don't get that yet, but if we just look at what's happening in New York, it's very obvious that that's going to be an issue. In Italy too, actually.
Yeah, thank you. Someone mentioned that they saw some calibration variables. They're wondering if you did some calibration, what you did with this model?
Yes, I've been working on calibration of this model. I haven't gotten to the point. Calibration is a tear your hair out. I haven't got much left to tear out kind of exercise, and I have got to the tearing the hair out, but not the aha moment with any of the calibration I've done so far. I'm hoping once things start locking down a little bit, I'll have a little more confidence in what the model is telling us about the populations that we're looking at.
How can you make the model more resilient given there's a data reliability issue due to politics, international relationships, panic, etc.?
So this goes down to some extent to calibration. Now, to be honest, in a situation like the one we are facing, there is no way in the world we're going to nail this. Probably after few years of research, we'll really understood exactly what happened during the first 6 months of 2020. But that's not going to happen in this kind of short time frame. And so, unfortunately, we build confidence to the best extent that we can. And we look at what's happening and we try not to stick to our guns and think that we were right at any point in time, because we're not going to be. And it's not just me, that's true for everybody.
Okay, there are a number of questions here about ventilators and how you know how many ventilators you would need. How would you know how many you would need, and what would happen when you run out?
So the answer to that is gruesome, unfortunately. Right now, the current hospital setting stuff, data suggests that if you end up needing to be put on a ventilator, you have a 40% chance of survival. If you are not put on a ventilator and you need to be on, you die. It's kind of black and white. So the number of ventilators is tiny relative to the potential for people who would need ventilators. And that's an in-hospital So as I said earlier, the majority of deaths would end up being out of hospital if this actually gets out of control, stays out of control. The majority of in-hospital deaths are exactly in that setting where people need a ventilator and they are not able to get one. And that's going to be a horrific, horrific situation for people if they're faced with it. This certainly did happen in Italy, unfortunately.
Okay, and then there's questions about the increased vulnerability of the poor in this pandemic and dealing with issues like that.
Yeah, I don't have any real information on that. A lot of that, when we get to the economic modeling, that's certainly where a lot of it is going to end up being focused, because we're talking about vulnerable populations, not to this disease, but to a variety of conditions, and we have dramatically increased the vulnerability of those populations to all of those conditions. And so when we get to the economic, adding in kind of the economic components of that, we'll be looking at that.
These models range from very basic to very complex. What is your opinion on complexity that's good enough?
So the last model I showed you, the one called ICU-09, is not quite there, but it is of the level of complexity that I consider close to good enough. And the reason I say that is we're dealing with pretty dramatic changes in attempts at social distancing and whatnot. And to understand how those are working, you need a fair bit of fidelity in the responsiveness of the model to different changes. And I don't think you can get that by the truly simplified aggregate models. So I think you need to build something out a little bit more. I don't think we need to go to a full agent-based representation, which in a sense is more accurate, but the computational requirements, those are all stochastic models. Computational requirements are almost overwhelming, given that you have to do thousands of runs for each run, so to speak. And I think we would end up kind of losing the battle there, but at the same time, I'm not a discrete event modeler, so I probably have a bias towards doing more continuous models.
Probably we're running out of time. Probably the last question. Is there herd immunity anywhere in your model? And
so
does it really
herd immunity simply means that the number of susceptible people goes down. So it really goes back to that R variable. When that R variable starts going down because there are fewer susceptible people relative to the total population, then at a point, if you get enough susceptible people, you get what is called herd immunity. And all it really means is that because of the way contacts work, you're as likely to come in contact with people who are already immune, more likely than you are to come in contact with people who are susceptible. So rather than having a disease that grows exponentially, you have a disease that flares up locally here and there, but doesn't end up being a huge public health problem to the broader population.
Okay, thank you.
All right, so thank you, everyone. This is a list of resources. I'm going to put the models up that I've shown you. Just as soon as we finish this, they will be up at that address. And we have a simulator up, a couple simulators up. There's another one that was done by Stephanie Glasser. That's pretty interesting. And there's another, I didn't get a chance to talk about it, but there's another way of doing the distributions of disease profiles that's written about on the blog, on our blog. And the upcoming webinar topic, sorry, that was a leftover I forgot to erase. Not relevant, my mistake. Thank you, everyone.